I'm going to try to give you an update on what else is new on the block. I'm not going to include the local treatment options, as Dr. Foster mentioned, Ozurdex or Retisert, and that might be my own bias because those are not, at least from my side, very favorable treatment options in young children. So at this point, we already know that uveitis in children is clearly more likely to lead to vision loss, most likely due to delay in diagnosis, as Dr. Foster and others mentioned, young age at onset that leads to extended burden over a lifetime that is likely to have an effect on academic and social life. Probably under treatment. Again, Dr. Foster emphasized that nicely because of the fear that is not really founded very well of the risks of adverse events from treatment. And most of our colleagues do not realize that by not starting immunosuppressive treatments early, I think they do truly believe that they're obeying the law of do no harm first, but not doing anything is not always doing no harm. So we try to emphasize that as much as we can. And amblyopia, of course, is a very important vision loss factor in vision loss in children. And one of the things I want to highlight here, again, is our pediatric ophthalmology colleagues really have done a great job in terms of sending these children for screening and all that. But I do feel that sometimes some pediatric ophthalmologists give up on these kids very quickly and do not necessarily employ aggressive enough amblyopia therapy, thinking that the child must have macular edema or other reasons not to see. So they don't push it as much as they push it in a strabismus kid with a strabismus, a cross eye, in other words. So I always sometimes find myself phoning in the pediatric ophthalmologist and explaining that there is no anatomical reason from our side that this kid should not see 20/20. The macular edema is clear. There is no leakage. The OCT looks beautiful. So that kid should have no reason to not see 20/20, but they're still 20/40, 20/60. So sometimes it falls on us to also push ahead with more aggressive amblyopia treatment as well. The prognosis in children, of course, is different than adults, and a majority of children do develop ocular complications from uveitis. We've already covered that. And long-term prognosis often depends on the findings at presentation, as we have talked about as well. Before going on to treatment, I wanted to just summarize recent findings that actually have been summarized as well. AC, anterior chamber inflammation on first exam, has a significant impact on prognosis. Presence of one complication increases the likelihood of developing another one, as has been shown by the Johns Hopkins paper. Risk of cataract development also increases with more than 3 times a day drops. This was also shown by Jennifer Thorne. And thanks to Dr. Foster's work, we also know that longer duration of remission on therapy seems to decrease the risk of disease flare after discontinuation of methotrexate. More reasons for aggressive therapy. With the evidence from, again, multiple papers, we know that use of immunomodulator therapy decreases the risk of vision-threatening complications like hypotony, epiretinal membrane, and blindness. And in patients whose chronic inflammation was eventually controlled within 3 years. Final bilateral vision was maintained within 2020, 2030. So this is good news, and it shows us that if we are aggressive enough in controlling and maintaining quiescence over an extended period of time, that we can achieve and maintain good vision. So those are reasons for aggressive treatment. Basic facts in treatment is already covered by Dr. Foster, so I'm not going to go into the details. This slide just shows you over time how our step ladder kind of evolved. And covering some of the older medications. So antimetabolites are one of the older medications. There's nothing new about them really, but it doesn't necessarily mean old medications are bad. Methotrexate, as has been repeated several times today, has a very good safety profile. We have a long track record with this medication in children. It has approximately 80% success in most children, and it is the oldest and most commonly used immunomodulator therapy of all. And again, Dr. Foster's study showed that if relapse-free survival after withdrawal of methotrexate was longer in patients who were treated longer than 3 years, who were older than 8 years of age at the discontinuation of treatment, and were quiet for over 2 years. So again, this supports the notion of long-term commitment to immunosuppressive therapy and being persistent about it. Azathioprine is one of the other antimetabolites that at least I don't use as often anymore. But there doesn't seem to be a whole lot of data in childhood uveitis either. There's one report that reports 60 to 76% success in JIA, depending whether it was used as monotherapy or combination therapy. Mycophenolate mofetil seems to work better in non-JIA pediatric uveitis. In JIA-associated uveitis, it was less likely to be effective. Again, not a whole lot of data, but we tend to use it more in non-JIA pediatric uveitis. Cyclosporin was shown to have a moderate success or humble success in JIA uveitis, and in a paper the authors showed no effect on macular edema, and they rightfully concluded that cyclosporin probably had limited value as a second-line agent in children. Although we use cyclosporin more often in adults, we don't use it as often in children, but there are certain children that can benefit from it. Biological therapy has been more commonly used over the past decade, and we talked about etanercept and its differential effect on uveitis versus arthritis. So we don't usually use etanercept for controlling uveitis anymore, but rather we go to infliximab and adalimumab. So these became the more commonly used anti-TNF agents, and I think a lot of us are quite comfortable instituting these medications pretty quickly in our treatment regimens. One difference is that, as I'm sure you all are aware by now, is that infliximab is an IV infusion, adalimumab is a subcutaneous injection, which is a little bit more easy to logistically use. And in several studies, adalimumab and infliximab have been found to be effective for refractory uveitis, mostly retrospective case series. There's also golimumab and certolizumab that I'm going to talk about. A comparative study of adalimumab versus infliximab was done. It was a prospective study, but a non-randomized trial in 33 children followed over 40 months. The major outcome in this study was flare rate. So the authors concluded that adalimumab and infliximab had comparable effect in achieving quiescence within 3 months, and also concluded that adalimumab might be a little more efficacious than infliximab in maintaining disease remission, although I would take that with a grain of salt because there were some bias by indication, and the doses and frequency of use of infliximab were different than standard doses, although adalimumab was used at a standard dose. So that might have influenced the results. Regardless, both seem to be have quite favorable effect on the disease. In a prospective multicenter study of 131 patients, of which 39 were JIA-associated uveitis, with 6 months of follow-up, 85% of patients experienced an improvement in inflammation, and they also experienced a decrease in concomitant immunomodulator therapy. So that seems quite promising. In 70% of those patients who had macular edema at onset, the authors also observed that the macular edema resolved. They had about 7% definite failures in that group. In a retrospective study of 17 pediatric uveitis patients treated with adalimumab, and this comes from United Kingdom, the authors mentioned that out of the 17, 9 were actually already declared anti-TNF recalcitrant patients who have already tried one version of anti-TNF and was not controlled, and all these patients were switched to adalimumab. And they noted 50% improvement overall in the entire group and had 3% that actually had worsened on adalimumab. They rightfully concluded that while it might be useful in selected cases, it did not completely obviate the need for systemic or periocular steroids, as a good proportion of these patients still required additional therapy. Other newer anti-TNF agents are golimumab and certolizumab. And golimumab is currently approved for rheumatoid arthritis, ankylosing spondylitis, and psoriatic arthritis. And correct me, Dr. Whalen, if I get this wrong. We don't we don't have any trials using golimumab or certolizumab at NEI, so I don't have much experience with these. But it was interesting to see how they are administered and whether they could be an option for our TNF-resistant patients, whether switching with medications within the same class would be helpful. And there's very limited evidence. There's case series of 3 refractory JIA uveitis case reports, and out of the 3, 2 responded favorably. So the authors conclude that it might be an alternative to other anti-TNF agents. But because they are already recalcitrant cases, it's not clear how successful they would be as a first anti-TNF choice. Certolizumab is also approved by the FDA for rheumatoid arthritis and Crohn's disease, and it involves 2 subcutaneous injections at the same time because of the dosing requirement, and that might be a downside in a child. Not only are you hurting them once, you're hurting them twice. And it's given 0 to 4 week intervals, then every 2 to 4 weeks. And I did not find any evidence in uveitis, childhood uveitis yet. Daclizumab, as Dr. Foster mentioned, is an anti-IL-2 interleukin-2 receptor antibody, and it's taken off the market, unfortunately, not because of safety concerns, but purely because of poor demand. So it wasn't so to speak, lucrative enough for the company to continue producing it, unfortunately, and we had to stop several patients who were responding very, very nicely. We did a prospective trial in a very small pilot trial in 6 JIA-associated uveitis at NEI back in 2009, and we had 5 out of 6 patients respond favorably, and 1 had treatment failure. Tocilizumab is another biologic relatively new on the block, at least from an ophthalmic point of view. It's a humanized anti-interleukin-6 receptor antibody. It's IV infusion. Again, I kind of note this because from a child's perspective and a parent's perspective, I think there's differences in logistics and how painful the process is in terms of whether it's IV infusion or sub-Q injection. It's IV infusion every 4 weeks. It's FDA approved currently for rheumatoid arthritis and systemic JIA. There is some anecdotal evidence in vasculitis. There's only a case series of 3 in JIA-associated uveitis, and again, rule of thumb, 2 out of 3 achieved quiescence. 1 was a treatment failure. But it is important to note that, again, these patients were already tried on conventional or standard immunomodulatory therapy and an anti-TNF or a beta-cept. So this is a very selected group of very recalcitrant patients. It's also important to note that in these patients, arthritis also improved along with the eye disease. Abatacept is a fusion protein that selectively inhibits T-cell co-stimulation. It is FDA approved for JIA and rheumatoid arthritis. Effect in JIA uveitis is limited, or evidence on the effect of JIA uveitis is limited. There are only case series and reports, I think it was 10 to 12 patients, and it was typically tried, when you look at these case cohorts, TNF-resistant JIA uveitis, so anti-TNF failures were included in these observations. And pretty much all these reported improvement in inflammation within 2 weeks to 6 months, although 6 months is a longer time to wait for quiescence. Average response seemed to occur around 2 months, and some of these patients appeared to remain quiet at lower doses later on beyond 10 months of treatment. So there's very limited evidence, but it looks like it could be, again, one of the alternatives to anti-TNF agents. Rituximab, as Dr. Whalen mentioned, is a humanized monoclonal anti-CD20 antibody. It's a chimeric antibody, so allergic reactions can be a concern, although we have pretreatment standards for those. It is FDA approved for rheumatoid arthritis and lymphoma. Typically, for uveitis, rheumatoid arthritis protocol is followed, which means IV infusions at baseline, and then 2 weeks later at a dose of 1,000 milligrams. The benefit of rituximab, again, as Dr. Whalen pointed out, is its long-term effect. So if you get 2 infusions, presumably, you shouldn't need... Did you have a point, Dr. Whalen? Okay. Presumably, if you get 1 cycle of infusion, the disease gets quiet and you wouldn't need another one at least 6 to 9 months. The retreatment criteria are not very clear, and when to do the second cycle is not very clear, but usually tends to occur around 6 to 9 months. There are a few case series for JIA-associated uveitis that is refractory to either conventional immunosuppressive treatment and anti-TNF. And in one of these studies, 7 out of the 8 achieved successful control of their inflammation. And in the other one, 7 out of 10 achieved successful control of their inflammation. The response to therapy seemed to occur within 2 to 6 months, and the recurrences typically occurred after 6 to 9 months, which is not too surprising. Again, the effect is believed to last about 6 months. I wanted to just give a case example of a 16-year-old girl with intermediate uveitis that was referred to us for treatment options. She was already placed on Cellcept after trying Methotrexate by her rheumatologist and primary ophthalmologist. And you can see here the diffuse leakage in the retina while she was on Cellcept, and after 2 infusions of infliximab, you can see the clearance in especially left eye, but both eyes. The vessels look much clearer, and you don't see all the whitish leakage. And another story that Dr. Foster probably will cringe where he's sitting is a child that was followed outside initially, a 12-year-old boy with bilateral anterior intermediate uveitis. He had tried Predforte, started prednisone 40 milligrams, had weight gain. Father was understandably concerned about side effects of steroids, and he was still active. And you can see his fundus pictures, slight hyperemia of both nerves, optic nerves, and a slight haze in the left eye indicating the active intermediate uveitis. And you can see from the history that it took 2 years to get him on Humira. After 2 years and many standard immunosuppressives and injections and topical steroids, he was started on Humira. He stopped cyclosporin at the same time. He was able to wean off of methotrexate within a year. And the fortunate part of the story is that he maintained good vision along this time, and he never developed any of the complications that are known to be associated with vision loss, cataract, posterior synechia, or CME. So while it took a while to get him on Humira, he did very well once he was on Humira. So between years 2 and 5, he was on Humira as a single agent and completely quiescent with no flare-ups. So we wondered what next, and the parents wanted to try taking him off of Humira. After being 3 years on Humira, 2 years of it as a single agent, we stopped Humira. And 2 months, within 2 months, he flared with 3+ cells in both eyes. Again, fortunately with good vision, but significant flare-up, and he's now restarting Humira. So while we can probably tailor out a regimen to get these patients quiet, we still do not know when the best time to wean patients off treatment. It is still a fortunate case with preservation of good vision, but it would be nice to know if we had studies showing when is the best time for what type of patient to stop the medications. In summary, uveitis in children is more likely to cause vision loss. Therefore, we all realize that early aggressive treatment of inflammation is critical. The fortunate part of the story, again, is that there are more treatments available today than 10 years ago. I have done my fellowship 11 years ago, and I am happily seeing that we have more options today to offer these children than we did 10, 11 years ago. We have many biologics, including many alternatives to the current anti-TNF, and early evidence does suggest that TNF receptor blockers are often effective in most cases, but if they are not, we do have other biologics as alternatives. And with that, I'd like to thank you.